sudden sensorineural hearing loss. This is an otological emergency, and the early diagnosis and treatment will lead to very good prognosis. So today we will go through what is the definition of sudden sensorineural hearing loss, causes, diagnosis, prognosis, treatment modalities and outcome assessment. So this sudden sensorineural hearing loss is an, as I already told, it is an otological emergency, more commonly seen in age group of 40 to 50 years. And in 90% of the cases it is unilateral, and the incidence is around 5 to 10 per 1 lakh population, and this was first described by a person, Declan, in 1944. So how will you define a case of sudden sensorineural hearing loss? And in the definition, the number 3 is important. So that is, sudden sensorineural hearing loss is sensorineural hearing loss of 30 dB or more. Okay, 30 dB or more. Happening in at least 3 consecutive frequencies. Contiguous or consecutive frequencies. Again, importance of number 3. 3 days or less. Okay. So this is the definition. That is sensorineural hearing loss of 30 dB or more in at least 3 consecutive frequencies in a pure tone audiogram, developing in a period of 3 days or less. And if there is no identifiable cause is detected, even after thorough investigation, it becomes idiopathic. Okay, so this is the definition of sensorineural, sudden sensorineural hearing loss. And there are so many causes of an sensorineural hearing loss. So that has to be differentiated from a sudden sensorineural hearing loss, so that early treatment can be initiated. And how can you know that this is happening? In most of the cases, there won't be any pre-morbid or the prior audiometry will not be available. Then how can you know that this is new or happening in a period of 3 days or less? And for that, the clinicians has identified 4 criteria to find out the level of certainty. And they are, that is, the first one is very certain. And in that case, there is a documented pure tone audiometry is available which was normal. And the patient is saying that he never had any hearing problem. Okay, so no hearing problem, and also a pure tone audiogram of normal prior pure tone audiogram is available. And certain, in that condition, we have to rely on the patient history. Patient tells that I have no hearing loss, I had no hearing problem also, and I am sure that my bilateral hearing was normal. Okay, in that case it becomes certain. So the patient saying as there was no hearing problem or no ear disease, and the bilateral hearing was normal. And fairly certain, in that condition, the patient telling us there is a long-standing hearing problem at present, and also there was a hearing loss, but suddenly my sensorineural or my hearing ability has gone poor, gone down. Okay, so in that case it is fairly certain. That also depending upon the patient complaint. Patient saying as there was a long-standing hearing problem, hearing disease, and suddenly it became poor. And uncertain, in that both the patient as well as the clinician is unaware of the hearing status of the patient. In that, these are the 4 types. And the most important thing is this has to be differentiated from a sensorineural hearing loss, because there are so many causes of sensorineural hearing loss, and it has to be differentiated from a sudden sensorineural hearing loss. So, what are the causes of sudden sensorineural hearing? In most of the cases, the exact cause of sensorineural hearing loss, sudden sensorineural hearing loss, cannot be identifiable. So, that is why it is called an idiopathic sudden sensorineural hearing loss. And the most popular postulations are, one is viral, especially by a herpes family, And you know, the acute infection with the herpes virus will lead to a sensorineural hearing loss, and the reactivation of the latent virus will lead to sudden sensorineural hearing loss. Second is vascular. Because the cochlea is supplied by an end artery, so any occlusion of the arterial supply can lead to a sudden sensorineural hearing loss, and that is why the drugs mainly given are proposed to or supposed to increase the blood supply to the cochlea. And third is an intracochlear membrane rupture, but there is no thorough evidence to show this. And next is autoimmune, and another one is Meniere's disease, because Meniere's disease can also present as sudden sensorineural hearing loss. So this has to be included in the differential diagnosis of idiopathic sudden sensorineural hearing loss. Okay, so these are the causes. And in the diagnosis, it is mainly by history, clinical examination, and also other investigations. One is history. And in the history, the most important is the onset of disease. Usually the patient will tell us, I noticed hearing loss on waking up from bed in the morning. And the short history is more in favor, or short history will have a good prognosis. Second will be a fullness or a blocked feeling, whether it is unilateral, laterality, unilateral or bilateral. Most of the cases, 90% it will be unilateral, and if bilateral, it is more in favor of an ototoxicity or an autoimmune disease. Okay, so unilateral is common in case of idiopathic sudden sensorineural hearing loss. If bilateral, look towards an ototoxicity or autoimmune disorder. Then a more profoundness or the more severe hearing loss is again in favor of bad prognosis. Then associated symptoms. So tinnitus, vertigo, and an oral fullness, and in 30 to 40% of cases they will be associated with the vertigo, which is again a very bad prognosis. Okay, and also you have to ask history of trauma, then straining, diving, flying, etc. And also, if you suspect any ototoxicity, take a detailed history of drug history and ask for a past medical history and rule out all the causes of sensorineural hearing loss. That is also very important. Okay, so onset, blocked or fullness in the ear, unilateral or bilateral, and if you suspect ototoxicity, take a drug history in detail. Associated symptoms as vertigo, associated vertigo is pointing towards a bad prognosis, and history of trauma, straining, diving, flying, and a detailed past medical history, and also history of any surgeries in the past. All these are important in history. Second is examination. A thorough examination of the head and neck, then otoscopy, especially to look for any wax, then cholesteatoma, secondary otitis media or otitis media with effusion, and also any infections in the ear. Do a tuniform test to differentiate it from conductive hearing loss, from sensorineural hearing loss, and fistula test to find out presence of any perineum fistula. Then a thorough neurological examination of the cranial nerve, and also look for cerebellar signs. These are very important in the examination. And third, investigations. In the investigation, most important one is pure tone audiogram, which will lead to diagnosis as well as prognosis, because a downsloping audiogram is very bad prognosis. Okay, downsloping is bad prognosis. Then gadolinium enhanced MRI scan, gadolinium, because you can exclude acoustic neuroma or vestibular schwannoma, and also you can rule out multiple sclerosis or a cerebrovascular accident. And in around 10 to 20% cases of acoustic neuroma will present as a sensorineural hearing loss at any one point of time. So that is important. And if due to any causes like presence of pacemakers or patient with claustrophobia or any other contraindication for an MRI scan, you can go with a contrast enhanced high resolution CT scan of the temporal bone. HRCT temporal bone with contrast. Okay. So if gadolinium enhanced MRI scan, that has to be done. If it is contraindicated, then go for a contrast enhanced HRCT temporal bone. And American Academy of Otolaryngology Head and Neck Surgery strongly against routine blood investigations. But by taking a history, history is pointing towards any identifiable cause. Then do a blood examination which include a full blood count or an ESR, urea electrolytes, lipid profile, glucose estimation, then thyroid function test, VDRL and also serology for a Lyme disease, and look for autoantibody if history suggests any of this. Okay, so history, examination and these investigations will point towards diagnosis. Coming to the prognosis, these are the four factors which point towards the prognosis. One is time since onset. The earlier the presentation, better will be the prognosis. Then age of the patient. Bad prognosis if the age of the patient is 60 years or more. Bad prognosis. Then vertigo. If the patient has associated symptom of vertigo, the prognosis will be bad. And in the Pureton audiogram, if it is showing a very profound hearing loss or a downsloping audiogram, showing a bad prognosis. But in any case, reassure the patient that 50% of the cases there will be spontaneous recovery without even any treatment. And by evidence, there is no a single treatment modality which is needed for this sensorineural hearing loss. The patient should be told about all the treatment modalities and the decision should be left to the patient. And also long-term follow-up is needed because there can be associated symptoms can develop in future, and also there can be fluctuation in the hearing loss, especially if patient with profound hearing loss, we need a long-term follow-up and also repeat audiograms are needed. So these are the four factors which directly point towards a prognosis. And what are the treatment modalities? All these are the treatment modalities. And anti-inflammatory immunosuppressants. Steroid is found to give maximum benefit in patients having sudden sensorineural hearing loss of 40 to 90 dB. That too, if you start steroids within a period of 2 weeks, maximum possible benefit will happen, and minimum advantage if you start it after 4 to 6 weeks. So that is the importance of early diagnosis and starting the treatment in a case of sudden sensorineural hearing loss. Steroid we give oral prednisolone. According to latest guidelines, oral prednisolone 1 milligram per kilogram body weight. Okay. Up to a maximum dose of 60 milligram per day, and this should be continued for 10 to 14 days. Okay, so oral prednisolone 1 milligram per kilogram body weight to a maximum of 60 milligram continued for 10 to 14 days. And if this is equivalent to 60 milligrams of oral prednisolone is equivalent to methyl prednisolone 48 milligram and dexamethasone of 10 milligram. Okay, so this should be started, and ideally an informed consent should be taken from the patient telling all the side effects of high dose of corticosteroids. That is very important. And antiviral acyclovir or valcyclovir is found to be effective by evidence. Then vasodilators carbogen, that is 5% carbon dioxide and 95% oxygen, or pentoxifillin. Then volume expanders can be given, dextran or hydroxydyl starch, calcium channel antagonists like nifedipine, and others like iron, vitamin, procaine, hyperbaric oxygen, ginkgo biloba, zinc, coenzyme Q10. All these are found to be effective, not single therapy, but a combination of all these will be better as per evidence. What is the role of intratympanic steroid injection in a case of sudden sensorineural hearing loss? These three are the indications. One is refractory cases. That is, even after giving the steroid along with other drugs in the prescribed for the prescribed time period, there is no response in the hearing. In that cases, you can try for an intratympanic corticosteroid, and also when the patient is presenting late, even after 4 to 6 weeks, you can try intratympanic steroids. And salvage treatment is intratympanic steroid along with a hyperbaric oxygen therapy. Regarding intratympanic steroid injection, I will discuss in detail later. Okay. So, refractory cases and when systemic steroids are contraindicated, and also to reduce the side effect of systemic steroid, because this intratympanic steroids will achieve superior perilymph concentration without systemic side effects. So, if the steroids are contraindicated and also if you want to reduce the side effect, you can give intratympanic steroids. And the commonly used ones are dexamethasone and also solumetrol, that is methylprednisolone, sodium succinate. And different papers or different evidence shows different dosing, but the commonly accepted dosage is dexamethasone 10 to 24 milligram per ml and solumetrol 30 to 40 milligram per ml. Okay, so and ideally, as I already told, not a single modality but a combination of different modalities are best for as a treatment of sudden sensorineural hearing loss, but the role of steroid is much appreciated in almost all evidence. Okay. For the clinical assessment of improvement, if the follow-up audiograms should be done within 6 months of occurrence of sudden sensorineural hearing loss. So, as per American Association of Otolaryngology Head and Neck Surgery, we can divide this into a complete recovery, partial recovery and no recovery, and this is in comparison with the unaffected ear. Okay. So, the patient says that there is no previous disease or hearing loss for the unaffected ear. That ear should be taken as a standard for comparison. So, in comparison with the unaffected ear, so return to within 10 dB hearing loss by Pearson audiogram and recovery of WRS, that is word recognition score, 5 to 10% of the unaffected or the normal ear, that is complete recovery. Partial recovery is in comparison with non-serviceable or serviceable hearing, that is depending upon the or as given by the American Association criteria. And there is no recovery if there is no gain even after completion of treatment for 6 months. Okay, so the most important thing in an sudden sensorineural hearing loss is that this is high chance of litigation in the treatment. So everything should be explained, the treatment modalities, the diagnostic dilemmas, if there is no identifiable pathology, that also should be explained to the patient, and everything should be documented. And also if you are giving a systemic steroids as well as IT steroid, informed consent has to be taken from the patient. So this is regarding sudden sensorineural hearing loss, and this is very important and in clinical as well as in theory part.